Welcome to this discussion. I want to talk to you a little bit about cannabis patients and legalization and where do we go from here. Subtitle to this is why we need a more medical rather than a less medical system, and I am Jordan Tishler. Just a little bit about myself. I went to Harvard Medical School a bazillion years ago, trained in internal medicine at the Brigham and Women's Hospital here in Massachusetts, and then spent a good 15 years working as an emergency room physician for the VA Medical Center. And around 2011, when Massachusetts started talking about medical cannabis, I thought to myself, you know, I've seen all of these veterans who've been harmed by all of these substances, in particular alcohol, and yet I've never seen anybody who was harmed by cannabis. And it made me start to think that, well, you know, if there's some evidence that cannabis could be helpful as a medicine, and we're certainly not talking about that, then maybe I need to learn something about it. So there ensued several years worth of my deep dive into the medical literature to find out what I could. As you might imagine, I went into that with a certain amount of skepticism, but emerged from my homework thinking that, in fact, cannabis could be a very useful medication for the right sort of patients under the right circumstances, and in particular at the right doses. That led me to look around and realize that few of my colleagues knew much about this, and furthermore that the federal prohibitions would prohibit my practicing this sort of medicine in the VA, of course, but also, more importantly, in any of the large private institutions like the Brigham or Mass General, because they receive pretty much all of their funding through the federal government. So that led me to form my private practice, inhaleMD, which was my way of being able to bring this therapy not only to patients, but then to be able to go back to these large home institutions where people knew me and to be able to present this data and show them why this is valid and how we could take care of their patients together as a team. Subsequent to that, I formed the Association of Cannabis Specialists because I wanted to elevate the level of care for patients. I wanted to make sure that physicians doing this sort of thing understood the data and were representing it well. And I wanted to make sure that physicians who would not do this sort of medicine understood enough about cannabis to know when they should refer patients to a specialist and also when not to. The association also has a mission of working with lawmakers to help them understand the importance and differences that patients have, and that's obviously part of what we're going to discuss today. And then last, the association is working intimately with industry to help the industry understand what it is that patients need, how patients are different from recreational users, and how they need to be treated differently. I'm going to read and discuss with you a number of quotations that I have heard from my patients over the last few years because I think they represent problems that we have in our current system and really exemplify the harms that come from these problems. Here's one. I don't know what your doctor is talking about. Don't listen to him. I'll tell you what to do. This was said to a patient who related to me by a large dispensary group, and ultimately that patient was telling me this in the context of the fact that they didn't get from that dispensary what it was that I had suggested to them, and in fact had been talked into a whole range of products which, when he went to use them, in fact made him sick. They kept trying to get me to buy more. They have volume deals and push other products. And what's up with the prize wheel? This isn't the Price is Right. This is an actual quote. And it really exemplifies the fact that when patients go to the dispensaries, they are treated as though they were a consumer, not a patient. And there are an array of sales techniques and tactics that are employed with or against these patients in a manner that confuses and suggests that they should be doing things other than what is medically appropriate for them. And we have to contrast this a little bit to our experience when we go into a pharmacy, where we go in with a prescription and, quite frankly, we get what we came for, and there's no wink, wink, nudge, nudge, hey, would you like a side of Percocet with that? That's because we recognize that patients are, in fact, a vulnerable population and are appropriately protected under the law. He told me to add this Keef stuff to my vaporizer, and now I feel sick, doctor. Why? Well, as you well know, Keef is a concentrated cannabis product with about 50% THC in it. That is well above anything that I would recommend to my patients. Typically, I would recommend a cannabis flower that is between 15 and 20% THC. But this case, this gentleman went and was advised, as you see, and as a result, he dutifully sprinkled the Keef on his flower. And mind you, despite my warnings to the contrary, and not surprisingly, this made him feel very, very sick. This should not happen. You are right, doctor. They immediately suggested CBD. It's a good thing that you warned me about how dangerous this could be for me. This exemplifies the fact that the sales agents in the dispensary, the budtenders, really have no basis for their recommendations. They do not know medicine, and they don't know the patient and the patient's past medical history or medications, allergies, or all of those pertinent facts. This quote came from a gentleman who, thankfully I saw this coming, came to me for routine back pain but had had a liver transplant. And so he was on medications for which CBD, or with which CBD can interact quite dangerously, meaning lethally potentially. And I was able to warn him that this was going to be a problem based on the budtenders' overeager and undereducated point of view about how to treat back pain. The current dispensing system is fundamentally good for the industry. However, it's not necessarily particularly good for patients. As we've discussed, there is a fair amount of misdirection in which patients are told things that are contradictory or confusing, and in particularly contradictory to what their medical professionals have told them. There is an array of upsell tactics like volume deals, as we've talked about, specials on this sort of thing, buy one, get one free, try this, try that. All of which go along with making false or at least unsubstantiated claims. You should try this CBD product because it will help you with your back pain, when in fact there is no evidence for that. And this stems from a mixture of inadequate medical knowledge on the part of the patient service advocate, which frankly, is not unsurprising. Most of these people are right out of college, and their primary source of information is the internet, about which we now have studies showing that 90% of the information on the internet is flat out wrong, and that only 3% of the information on cannabis is coming from reputable and qualified sources. Additionally, their other primary qualification is, yeah, I like to smoke weed too, man. And frankly, that's not a very good basis for giving medical advice. But in many ways, they're put in a very awkward position, and this is not entirely their fault. The system, both regulatory and the business interests, have put them in a position of trying to sell something that they really don't know that much about. And this sets up a tremendous conflict of interest between the advice that they're giving the patient and their need to sell. And we really should be separating that advice from the point of sale. What we have to understand is that patients are simply not the same as recreational users. They're coming from very different places, and they have very different goals, and they often we find these goals are exactly the opposite. Recreational users. First of all, let me preface this by saying that this is absolutely legitimate. However, it is different. Recreational users are there because they love the ride. They're looking for an experience. They're looking for what's new, what's exciting, and experimentation with different doses and different products and different ways of taking it. All of that is part of the fun. And maybe a plus, maybe a minus, the ultimate goal or mentality here is that more is better. We want to contrast that, however, with patients. Patients' goals are simply to feel normal. They have a problem or a set of problems, all of which are making them feel worse than what they used to be. And here they're looking for help, and they simply want to get back to feeling like themselves again. The high or intoxication, which is really what people are interested in a recreational sense, for patients is a side effect, generally speaking, an unwanted side effect. This leads us to acknowledge that that side effect goes with the territory, but that we must manage it, and leads us to the idea of the minimum effective dose, which is a concept throughout medicine. But really what we're saying here is how little of the medicine can we get away with using to get the benefit that we need and thus minimize the side effects. The other thing we have to understand about medical patients is that they're rarely simple. They often have multiple complex medical problems with long past medical histories that are, again, fairly complex and sophisticated. They're taking multiple medications, many of which may be fairly dangerous if not used properly or if there are drug-drug interactions. And we need to be able to be sure that we are treating them in the safest as well as the most effective manner. In many ways, the problems that we're seeing now in the world of cannabis medicine harken back to problems that we had 100+ years ago in an era we call the patent medicine era. This was an era that ranged really from sort of 1865 up to 1934. Certainly existed somewhat before that, but it hadn't become kind of a booming business until after the Civil War. This era, unfortunately, was typified by manufacturers putting forth treatments that did not meet what we would consider a reasonable standard of evidence. So they often put forward these medicines with unsubstantiated claims. And this may have been offered by the seller of this medication or by the manufacturer directly. But in any case, they would often say things, this is good for this, or this is good for that, or this may treat the other thing, but without any research or without any conclusive evidence to support those claims. Similarly, there was very little, if any, quality control, so that products had high variability in terms of the consistency of the ingredients, and more importantly, there was no safety testing, so that there was no thought given to contamination with various agents, particularly heavy metals and other hydrocarbons. And then, of course, there's the fact that there was no need or attempt to prove efficacy. And so, in fact, patients were often taking things based more on wishful thinking than on known outcomes. As a result of the challenges put forward under the patent medicine era, the federal government moved, following many of the states' moves in 1934, to institute laws and regulations. They signed into law the Food, Drug, and Cosmetic Act of 1934, and the FDA was born. Their job was to establish safety regulations, to figure out how to standardize medication doses across different types of medication and different delivery systems. The law defines a prescription as having a medication, specific medication, dose, the route of administration, the frequency, and most probably importantly, a sales amount. And in doing so, not only did that increase the specificity and communication between the clinician and the patient, but it also established sales limitations on the seller, which protect patients from the kinds of upselling and misdirection abuses that we're seeing presently. And this, therefore, addresses the issues of the conflict of interest that we've seen between the sellers purveying of product and the advice that they're given. And in fact, under the pharmacy regulations, there are very strict rules about who can say what to patients, so that if you go into a CVS or other pharmacy and start to ask the cashier about how to use or why to use a particular product, she or he will rapidly say, "I'm sorry, I can't answer that question. Let me find you somebody who can." And they will get you to a pharmacist who is somebody with 4 years of training on medications. But even they have limitations on what they can say about medical care, because in fact, while their expertise is in medications, it's not about medicine in the broadest sense, and that is where physicians and other clinicians come in. And so if you ask the pharmacist about your disease, they are going to tell you that you need to speak to your clinician. And that is a very tightly controlled, appropriate system so that patients get the right information from the right knowledgeable professional. So where is the FDA now when we need them so much when it comes to cannabis? Well, I think the FDA is in an awkward position themselves. I have no doubt that as a group, they would very much like to be able to influence the safety and efficacy of all of the medications that are being used, cannabis included, but federal prohibition really has tied their hands and has kept them from taking their otherwise appropriate actions. They can really only regulate based on data, and again, their hands are tied by the Schedule I status of cannabis. Interestingly, the FDA has at times made statements that they are sort of unsure how to address cannabis because it is a polychemical mixture, meaning it has many, many different chemicals in it, which don't seem so simply purified because we tend then to lose the beneficial action of the medication. It turns out that the FDA does have a botanical pathway for regulating botanicals. The problem is that it's sort of out of favor and out of service since the more modern pharmaceutical approach has come on board. But there is a precedent there that I think we need to re-examine and perhaps reinstitute. And just to my point, I suspect that the FDA is rather eagerly awaiting the opportunity to get involved in this space. So what would a federal medical system do, and what would it look like? And, you know, tangentially, how can states emulate this to help the federal government understand the things that we need and to really be a shining light to the nation? You can see that I have a number of bullet points here. The first thing is that we need in the cannabis world to get to those exact prescriptions. There's some discussion about just exactly how exact they can be given our state of knowledge, but nonetheless the point needs to be that within the bounds of what we know at the moment, we need a system that allows clinicians to be as specific as possible and to know that having done so, there will not be any attempt at the point of sale to contravene or contradict that prescription. Similarly, such a system really needs to clamp down on the medical claims. It is not acceptable for the seller to make claims about what a medication will or will not do for a particular condition unless there's solid scientific evidence to show that. Moreover, the persons making such claims really ought to be appropriately qualified to make those statements. And these statements, these medical claims, should neither be made by the point of sale agent nor by the manufacturer of the product. A federal system really needs to develop or facilitate interstate operability. And where this comes up a lot is around transportation of product from state to state, and I think that that can be handled on one hand, but the other area that is particularly germane to patients is the idea that people travel. Here in the Northeast, many of my patients are snowbirds and spend a significant number of months each year in warmer climes, particularly in Florida, and there needs to be a mechanism by which they can take their medication with them when they go and potentially to purchase medication when they get down to wherever they are going, just like they would be able to do with any conventional medication. There needs to be a development of some common safety standards. In Massachusetts, where I live, I believe that the testing, while not perfect, is a pretty good start. But there are other jurisdictions across this country where there is no regulation whatsoever requiring testing. And that's true in particular in Arizona. And interestingly enough, in Colorado, the testing standards under the recreational rules are more stringent than those under the medical rules. So we need to come up with a set of rules that are national and protect the patient to the fullest extent that we can. A federal system really needs to provide for clinical discretion to the clinicians who are qualified and most capable to make these decisions. And what I'm really talking about here is the ubiquitous list of conditions. Unfortunately, those lists of conditions are not really based in scientific reality. They are based upon lawmakers making regulations that, frankly, they're not equipped to make, based upon the recommendations of advocacy groups who have political agendas, but again, not clearly the best scientific data, nor, frankly, the best interests of patients as a whole. The list of conditions really needs to be eliminated, and we clinicians who have trained long and hard to be able to understand the data that exist and the clinical experience of practicing medicine need to be able to exercise the judgment for which we have been trained. Massachusetts is a good example of how to do this. We have a list of 8 conditions which the law relegates to examples by a codicil which says, or any or all other severe and debilitating conditions as determined by the physician, which means, again, that things not listed on that list of conditions may be treated with cannabis so long as they meet the definition of severe and debilitating and the physician or other clinician is appropriately taking care of those problems. Something that is nice about the system in Massachusetts is that we can get some purchase feedback. Patients who purchase at a dispensary have their purchases logged and are available for review by the clinicians through the state system. And this is something akin to the various state PMP systems that allow us to check for opiate and benzo purchases. And it provides a very useful feedback for clinicians who need to understand what it is that their patients are doing and how much they are purchasing. We also need to acknowledge that there is a potential overlap between medical systems and recreational systems. Again, I would offer that recreational systems are perfectly legitimate, but they need to be viewed as separate from medical systems because the needs of the two groups are radically different. But we also need to understand that if people are choosing to participate in the recreational system rather than the medical system, they still need to be protected for safety reasons against contamination and other things, but they also should be protected against the same predatory sales techniques, so that if somebody comes into a recreational store and says, "What have you got that I will enjoy this weekend?" a lovely sommelier-esque discussion can ensue. But if they come in saying, "What have you got for my backache?" then the dispensary really should be saying, again, "I'm sorry, this is a medical question. We're really not equipped to deal with this. Here is a list of physicians or other clinicians who would be more than happy to help you with this issue." And so we take patients who are not necessarily thinking of themselves or deciding to participate in the medical system, but have a medical problem or medical questions, and shunting them to the appropriate level of care. And ultimately, a federal system or a forward-thinking state system should be setting a research agenda around the questions of how best to use cannabis and how can we get more data to facilitate the understanding of what cannabis can and cannot do, what are the safety parameters, and what are the components within cannabis actually doing. All of these things are necessary for us to move forward in a system of medical cannabis that serves patients well and provides for them both the best benefit and the best safety. Let me mention again the Association of Cannabis Specialists, the purpose of which is to increase the standard of care for patients, to make sure that patients are getting the best care that they can, and to provide education to physicians who are either going to provide that care or perhaps not provide that care, but provide referrals for their own patients to specialists to provide cannabis care. We want to work with dispensaries and product manufacturers to help them understand the needs of patients, the types of products patients need, and the kind of care that patients need at the point of sale. We want to encourage research, and we want to work with lawmakers to improve the law and regulation to meet the goals as we've outlined at the previous slide. You can learn more about the Association of Cannabis Specialists by visiting us on the web. The URL is cannabis-specialist.org. There is a wealth of information there. And last, let me make myself available to you. If you have questions, please reach out to me. The best way to reach out to me, of course, is by email. My email is doc@inhalemd.com, and I welcome any and all questions. Thank you so much for listening to me today.